Hi everyone, my name is Jayanti, and today we are going to discuss a case study and feedback on low back pain assessment and spinal injection referral criteria. So, a patient was sent to IMSK clinic, which is a triage clinic, requesting a referral or consideration for a spinal injection referral. So we'll discuss couple of points with regards to identifying the documentation gaps, applying the NICE guidelines, and critique the diagnostic reasoning to see whether it is appropriate referral or not. So, subjective history is provided. Patient is 40-year-old, pain and discomfort across lumbar region, radiating down the right leg to foot for a year. Pain is getting worse. Patient is not working, struggling to continue with the job. Self management and exercises has been tried but unhelpful. Visual analog scale is 7/10. Pain is mostly present all the time. Sleep is affected. Patient has tried diazepam, naproxen, omeprazole, and cocodamol, keen to explore facet joint injection or surgical intervention. Objective examination and imaging information has been provided. So, gait is patient is limping on the right side. Range of movement is 40% painful at the end of range. Forward flexion is the most painful. L4, L5 paraspinal tightness, struggles to touch shin while forward flexion. Extension and side flexion is painful at the end of range. Pain radiates to right foot. Straight leg raise is less than 30 degree, no bony tenderness on palpation. Activities of daily living is impaired. Manual muscle testing is 4 minus 5 in the entire right leg. Left leg, the patient has got full muscle strength. Patient is struggling to do heel and toe walking. Reflexes are normal. Babinski is negative. No cauda equina syndrome signs. MRI was done in February 2026, which is described as annular tear at L4 L5 level, small central disc protrusion. Now the impression has been given as L5S1 radiculopathy, and the request is for expert opinion regarding the further treatment. So I think looking at the referral, we can see clearly here a mismatch at the MRI level as well as the clinical impression, but also it's been put a question mark to the clinical impression. So we'll discuss that. So this referral is currently insufficient for submission. So at the triage, I would reject this for injection for um, spinal referral or injection, and I'll give you the reason why. And probably I would request the clinician to provide some more information. So there are a few gaps in the subjective and objective examination. As discussed, MRI level versus clinical impression, there's a mismatch, it doesn't align, and NICE guideline criteria is not fully met. So, coming to the subjective history, the pain character is undocumented, which means they have not described what kind of pain is that, whether it is a radicular symptoms or it's a facet joint symptoms. So, like burning, shooting, aching, constant or intermittent pain. No aggravating or easing factors has been described. No postural relationship has been described. This is very important to understand whether it is a radicular pain or mechanical pain. Coming back to the neurological symptoms, they have not described whether the patient has got paresthesia, numbness, or dermatomal sensory symptoms. Central requirement for radiculopathy. So patient has got a central disc bulge, so you want to know if there is a nerve root compression or not. Conservative management is not fully evidenced, so NICE requires more than 6 week structured program. Self-management is insufficient for me. What I want to know is that how long they have done the regular strengthening exercises, what exercises they have done, what has been their lifestyle during that time, and what is going around in their life in terms of psychosocial factor, their well-being, how they are coping at work, at home, and social life. In terms of management, what kind of treatments have been tried so far and how long for. In terms of exercises, we want to know the type of exercise, whether it was core stability, it was any kind of motor control exercise, yoga, gym work, or strengthening. What was the frequency and duration? Red flag screening, there's no explicit documentation of red flags exclusion beyond cauda syndrome. So, like weight loss, fever, bilateral symptoms, systemic symptoms not addressed. Contradiction in employment, it says not working versus struggling to work with the job. So, I don't understand if the patient is off work or because they were struggling to do the job, hence they are not working. So, I think that needs to be really specifically written. If the patient is off work, then it is a priority to bring them back to the work, and that will give a little bit of indication towards their motivation and supporting them to return to work. If they're not working, then the management is going to be slightly different in terms of providing more psychosocial support, more cognitive behavioral therapy, or functional rehabilitation, etc. So I think that's important. There is no validated outcome score done in terms of patient specific functions or start keel back. Coming to the objective examination, neurological examination is complete. Reflexes are not specified by the level. So they have mentioned the reflexes are normal, but they have not mentioned knee or ankle and at what level. Babinski was mentioned negative, it should be actually going downwards. No dermatomal sensation testing has been documented. Myotome mapping is absent. Straight leg raise is not lateralized. So the notes have documented that SLR is limited 30-degree, but side not specified. Cross leg SLR, braggarts, and bowstring sign absent, which are very important for standard confirmatory test. Heel toe walking is very imprecise and too vague for me. So no laterality stated, which means L5 is tibialis anterior versus S1 is gastrocnemius. Where is the weakness, or if there is any weakness? I think that will be really helpful to understand the myotomal level and if there is any radiculopathy. Coming back to MMT grading, it's too vague for me. Right leg 4 minus 5, it doesn't make any sense to me. So, which muscle groups are affected? If you're talking about the disc bulge and lumbar radiculopathy, we need to be very specific whether it is L4, L5, S1, and document the myotomes individually for the localization and nerve root correlation. Range of movement for the spine is imprecise. 40% and half are not standardized range of movement. Goniometry is fine, but what we need to do is that fingertip to floor and distance required in terms of side flexion and extension. Gait type is not characterized, so I think that is very important in terms of understanding if there is any radiculopathy and if the weakness is due to pain inhibition or is it actually nerve root compression. So when it comes to diagnostic, there is a mismatch between the MRI documentation versus clinical impression, and that's absolutely fine as long as the subjective and objective information is matching with your clinical impression. But here, that subjective and objective clinical information is not correlating with the clinical impression. So, what we have to do is that we just cannot take the MRI report as it is and correlate with the diagnosis. So, MRI findings suggest that L4, L5, there is an annual tear and small disc central protrusion. So, central protrusion usually gives bilateral radiculopathy or cauda syndrome, that is more likely. Foraminal and paracentral usually gives a unilateral radiculopathy. So here it's written as clinical impression is L5S1 radiculopathy question mark. So I'm not convinced with the question mark whether there is a confidence in the clinical impression, but also there's a lot of information missing in the subjective and objective information and testing. So, looking at the teaching points, what I want to emphasize here is that L4 L5 disc typically compresses L5 nerve root. Foot dorsiflexion weakness would be present. EHL weakness, which is the big toe extension. Medial foot and big toe sensation would be affected. It will have normal ankle reflex or ankle jerk. Whereas L5S1 disc radiculopathy or disc compression typically compresses S1 nerve root. You'll have a weakness in your plantar flexion, so patient won't be able to or struggle to do the toe walking or heel raises. Absent ankle jerk, lateral foot or heel sensation would be disturbed. So the clinical findings of MMT 4-5 heel/toe walking difficulty must be mapped to the MRI findings. It can have a different objective finding, which means if MRI says that there's a disc bulge at L5, L4, L5 level, and your clinical impression can be absolutely different provided you have provided all the subjective and objective information which is matching with your clinical impression. Currently, we don't have that information, and there's a mismatch between the clinical impression, MRI findings, subjective and objective findings. Coming to NICE criteria compliance, the patient information is provided is confirmed radiculopathy plus imaging. MRI level is provided, but there's a mismatch between the objective findings and the MRI report. Symptoms duration, of course, patient has a 1 year symptoms. It's more than 6 weeks for radicular pain. That's been documented. Structure conservative management should have been tried as per the NICE for more than 6 weeks. They have stated that they had conservative management, but it's not documented what treatment they had and how long for. Red flag exclusion for Cauda-Equina syndrome has been screened, but other red flag symptoms, including systemic symptoms, are not screened. Validated outcome measures are not documented, so they have not met that threshold. Psychological screening for psychosocial factors are not documented, so that's absent despite clear indications. MRI level and evidence of report has been provided, but there was no imaging. So sometimes you can get a report, but if you look at the image, it may not correlate. So I think it's very important to have the image and report and then look two together. They have requested injection type and is facet joint injection. For central disc bulge, we don't provide facet joint injections. I think it would be more appropriate to request transforaminal epidural spinal injections or epidural spinal injections if there is a radiculopathy and it's unilateral. Confident in working diagnosis, no uncertainty markers. So basically, they have put a question mark in their impression, which means they themselves are not confident in clinical impression. Then it's very unlikely that we can refer this patient for spinal MD discussion or a spinal injection referral. Cauda-Equina syndrome has been excluded and this has been documented very well. Specific referral question is not mentioned. They are asking for expert opinion is too vague. So we want to know very specific question. Okay. So 5 out of 11 criteria has not been met. 3 is partially met. So here just wanted to highlight that a facet joint injection would not be appropriate for this patient. Pain is predominantly axial, which means back dominant than the leg, worsened by extension and rotation. Positive facet joint loading test and no true radiculopathy pattern. This patient has radicular symptoms. Facet joint injection is not indicated target as written here. For facet joint injections, you have to have a back dominant pain. There shouldn't be any leg pain. and their symptoms has to be worsened with the extension rotation. This patient did not have that. Positive facet loading test should be there, and there shouldn't be any true radicular pattern. Coming to transforaminal epidural steroid injection, so confirmed unilateral radiculopathy, dermatal pattern into the right foot has not been described. MRI confirms nerve root level. Conservative management should have been tried adequately. In this case, we don't have that information. Um, the suggested wording should be, please review suitability for right transforaminal epidural steroid injections given L4, L5 disc pulse pathology, radicular symptoms, weakness in a specific myotome, and for how long. If the patient is getting worse, better, staying the same, we need to know that as well. Okay. So consider spinal MDT discussion first. Psychosocial complexity needs to be explored as well. Diazepam use, sleep disturbance, and work ambiguity really affects the injection candidacy and outcome prediction. So all this information needs to be there before we proceed. So what needs to change here? Resolve the MRI level versus clinical impression mismatch. Clarify whether it is L4, L5 in MRI versus clinically L5S1, and re-review the MRI laterality. Remove question mark from the impression. State confidently based on your subjective and objective information. Plan a working diagnosis or explicit differentials. Add validated outcome measures like patient-specific function score or start back score. State a specific clinical questions for receiving the specialist intervention. Include dermatomal sensory symptoms like history of paresthesia, numbness, or burning. Complete neurological exam. Specify the reflexes by level, dermatome sensation, and individual myotome testing rather than the whole leg. Change injection request from facet joint to evidence-based target transforaminal epidural steroid injection with clinical justification. Specify conservative treatment, what kind of treatment they had and how long for, whether it was physio, anything else, duration, frequency, compliance, and response. Document full red flag screening explicitly, not just Cauda-Equina syndrome, and address the diazepam prescription. Diazepam is usually not prescribed for low back pain. Resolve the employment contradiction and add functional context, whether the patient is off work or not working because of the back pain. So what we have learned so far is that MRI finding must be clinically correlated by level and laterality. A central protrusion at L4, L5 is not automatically an L5S1 radiculopathy. NICE has clear standards for spinal injection referral, document conservative management, validated outcome scores, and full neurological assessment, not just the imaging. Injection type must be justified via clinical reasoning. Facet versus transforaminal epidural steroid injection versus nerve root block are distinct interventions. The clinical picture must drive the injection target, not patient preference alone. Uncertainty in an impression is a red flag. If there's a question in the diagnosis which has MRI findings as well as subjective and objective information, then that's not a very confident clinical impression or diagnosis. So that needs to be confidently assessed first. Psychosocial factors matter more than imaging and objective and subjective history, so explore that in your subjective history. And as mentioned, diazepam prescription needs to be looked into. Sleep disturbance, employment ambiguity are not incidental. They affect injection candidacy and referral criteria. So this was a very brief information on how to refer a patient, but also compliance with a NICE guideline. I hope this helps.